and welcome to today's episode of the Central Ray Podcast, the podcast that helps you whether you're a student prepping for the ARRT Registry Exam or a practicing technologist keeping your skills sharp for CQR. I'm Ryan Ross, and today we're diving into a really important and often overlooked section of patient care, pharmacology. Now, I know what some of you might be thinking, wait, I'm a radiographer, not a pharmacist. True enough, but as imaging professionals, we administer contrast media every day, document medications and patient histories, watch for allergic reactions, and sometimes even assist in emergency situations that involve drugs. That is why the ARRT exam expects you to understand the basics of pharmacology as it applies to radiology. So grab that coffee, take a deep breath, get your pen and paper ready, and walk through the key concepts you'll need to master. Let's start where we start with every patient, their history. One of your responsibilities is to document a thorough medication history, also called a medication reconciliation. Do you know what medications your patient is currently taking? This is critical because certain drugs can interact with contrast agents or indicate potential risks. For example, if a patient is on metformin and you're giving iodinated contrast, there is a risk of lactic acidosis if their kidney function is impaired. Next, we have to consider pre-medications. Some patients with a history of contrast allergies may need pre-medication, like steroids or antihistamines. We also need to be aware of contraindications. Does your patient have renal impairment, a known iodine allergy, a bowel perforation? These conditions could make certain types of contrast inappropriate. And finally, scheduling and sequencing of exams. If a patient is having multiple studies, the ones using contrast should generally come after other studies to prevent artifacts or reactions from interfering with additional imaging. So here's a quick question for you. If your patient just drank barium for an upper GI, should you schedule a CT with contrast straight afterwards? Hint, probably not. Barium can obscure CT findings. Always think about the order of exams. Part 2, administration. Now let's talk about actually administering medications, or more commonly for us, contrast media. You need to know the routes of administration. In radiography, we typically use IV for intravenous, and this would be for iodinated contrast in CT or venography. Oral for barium or water-soluble agents in GI studies, and then rectal as if we're doing a contrast enema. We always use supplies like enema kits, syringes, needles, and IV catheters, so you should be familiar with how to set them up and to use them safely. Procedural techniques matters too, especially with venipuncture. Even though in some states technologists are limited in starting IVs, you still need to understand the principles so you can assist or perform the task if it is within your scope. And don't forget dose calculation. In pediatrics especially, contrast dose is often based on weight, for example milligrams of iodine per kilogram. Part 3, contrast media types and appropriateness. Next is one of the most testable and clinically important topics, contrast media. There are different types of contrast agents. Iodinated, which is water-soluble, for vascular or GI imaging when perforation is suspected. Barium sulfate for GI studies when there is no risk of perforation. And within the iodinated agents, we have ionic versus non-ionic. Ionic agents dissociate in solution, are higher osmolality, and more likely to cause reactions. Non-ionic agents are preferred today because they are safer and better tolerated. Then you have to consider whether the contrast is appropriate for the exam. For a suspected perforated bowel, water-soluble iodine, not barium. For a young child, you have to adjust for weight. If the patient has impaired renal function, maybe avoid iodinated contrast or use a lower dose and hydrate them well. When we're talking about renal function, we have to know lab values. The BUN or blood urea nitrogen, creatinine and the eGFR, the estimated glomerular filtration rate. You do not need to memorize exact normal lab ranges to the decimal. The exam typically tests your understanding of the concepts. BUN and creatinine essentially assess kidney function. Impaired renal function increases the risk of contrast-induced nephropathy, sometimes called CIN as an abbreviation, and also that a very low eGFR, typically below 30 milliliters per minute per 1.73 meters squared, is usually a contraindication to contrast without physician override and precautions. So for BUN, an approximate normal value is 7 to 20 milligrams per deciliter. It's a clinical concern if this number is over 20 to 30. It may suggest renal dysfunction. Creatinine is 0.6 to 1.2 milligrams per deciliter, and a range greater than 1.5 may indicate impaired renal function. And then an eGFR, the normal range is greater than or equal to 60, but anything less than 30 is generally a contraindication for contrast. Common reference values you should know conceptually. These tell you how well the kidneys can handle iodinated contrast. Always check renal function before administering iodinated contrast. Elevated BUN and creatinine or an eGFR below 30 indicate impaired kidney function and may be a contraindication, so consult the radiologist or the ordering physician. Part 4. Complications, reactions and your response. Finally, we have to talk about what can go wrong and how you can handle it. Contrast reactions can be local or systemic. Local effects include extravasation. This is when contrast leaks into the surrounding tissue, and this can cause swelling and pain. So stop the injection, elevate the limb, and apply a cold or warm compress as appropriate. Systemic reactions fall into 3 categories. Mild, things like nausea, vomiting, urticaria, which is hives, or mild itching. Moderate are more significant urticaria, bronchospasms, and hypotension. And then severe, resulting in anaphylaxis or potentially cardiac arrest. You must recognize these reactions and know your role. Stop the contrast, call for help, begin emergency response, including and using an AED, oxygen, or medications as directed by the code team. It is also your job to document everything. Include what happened, what you observed, what actions you took, and how the patient responded. If a patient starts complaining of itching and develops a rash after contrast, is that a mild, moderate, or severe reaction? The answer to this would typically be mild to moderate, but always monitor the patient closely. Whew, that was a lot of ground to cover, but this is truly critical knowledge for both the exam and real-world practice. So let's quickly summarise. Take a thorough medication history and watch for contraindications. Know your contrast agents, the types, properties, and when to use them. Understand administration techniques and dose calculations. Be prepared to recognise and respond to complications, and always document thoroughly and accurately. Remember, your expertise here not only keeps your patient safe, but also builds trust and professionalism in your role. So before we go, here are some 3 questions or 3 thoughts for you to consider as you review. 1. Why is it important to ask about metformin before administering iodinated contrast? 2. When would you choose a water-soluble contrast over barium for a GI study? And 3. How would you document an extravasation event after it happens? So take some time to reflect on these and maybe even jot down your answers. It's great practice. So thank you for joining me on this episode, and I will see you on the next one.